So there were 8 abstracts. In the message there was that you can present only 4, and I chose the message in email that yes, I will present only 4. So they're all in HER2/neu arena. There are 2 initial trial which will talk about addition of immunotherapy in a neoadjuvant setting. So we'll start with the phase 2 Korean data. And the logic is that HER2/neu drugs utilize immune mechanism like ADCC to work, and there's a preclinical data suggesting that if you add immune therapy, then possibly the effect will be augmented. So that's the logic. What they did was that in the TCHP arm, they removed carboplatin and they added atezolizumab. The logic was removal of carboplatin will decrease the toxicity, but introduction of immune therapy will overcome that, provide efficacy and decrease toxicity. It was a phase 2 trial, 67 number, and like Catherine, adjuvant TDM1 was allowed. So it's a relatively a new data set because many of old trial would not have allowed adjuvant TDM1. Endpoint was PAT-CR rate. I'm sure Amol would have some issues about it. Correct? Okay, so they wanted to prove what will be the PAT-CR after removal of carboplatin and addition of immune therapy. And the PAT-CR rate was around 60%, more so when it is HR negative, more so when it is early disease, and all PD-L1 positive population had a PAT-CR. So they could prove the fact that like in Christine and Trifina, one could achieve a PAT-CR rate equivalent despite removal of carboplatin with addition of atezolizumab or hopefully any other immunotherapy. They wanted to prove that withdrawal of carboplatin will lead to reduction in toxicity, and their measurement was that in their hand 40% of patients had the withdrawal or dose reduction, whereas when they replaced carboplatin with atezolizumab, the dose reduction was reduced. But I think the answer actually comes from the second trial. The first was the phase 2 trial. So IM PASSION 050 trial answers this question rather well and negates the phase 2 trial. Philosophy was same, the patients were largely same, immune therapy was same. But instead of TCHP, they chose dose-dense AC and weekly paclitaxel with trastuzumab and pertuzumab. The standard in a way, but we don't use dose-dense AC pacli, we use TCHP, but that's an acceptable chemotherapy. And they added immunotherapy in the comparator arm. And this also being a relatively new trial, they added TDM1. The primary endpoint was pathological complete response. But they could not find any differences in pathological complete response despite adding atezolizumab. In fact, if there was any improvement, then it was in PD-L1 negative population, not in PD-L1 positive population. So they could not prove that. There was not a single group in which addition of immunotherapy added anything to this population. The toxicity was incremented by few percentage, largely because immunotherapy has its own 5% to 10% toxicity, but nothing new was sought. So they wanted it to be a more effective treatment. Sorry, it was not more effective, it was possibly less effective. It was supposed to be equivalent toxic, slightly more toxic, but yes, it was slightly more toxic. The author raised a question that we answered based on PAT-CR. Maybe an event-driven data like a PFS, EFS, DFS or an EFS would have been answered, which was suggested in a durvalumab trial, JEPAR-NUOVO trial, in which the PAT-CR were similar, but the EFS rate was quite good, as good as Keynote 522, raising a question that is PAT-CR an appropriate endpoint with immunotherapy. Like Keynote 522, surprisingly, PD-L1 positive population did worse off, and PD-L1 negative population did much better. I believe a driver-driven tumor should have drugs better for the driver, like TDXD for HER2/neu. And it is in that setting, like what Koreans do, or like APT trial did, chemo de-escalation is feasible. At this point of time, there is no role of immunotherapy in this setting. Kathleen, now we move to adjuvant setting, and in this, the standard arm was anthracycline and trastuzumab, pertuzumab with taxane. That's kind of what we do standard. And they did not want to give taxane because they believe that taxane has significant toxicity. So they removed taxane and trastuzumab and moved to TDM1, a very costly way of replacing taxane. But anyway, they wanted to reduce taxane toxicity. They also believed, like in Catherine, that HP may leave some resistant clone and TDM1 possibly is more effective. So they believe they will reduce the toxicity, they will make it more efficacious, and the endpoint was IDFS in node positive population. Well, nothing. Node positive, no extra benefit. Overall, no extra benefit. Toxicity, surprisingly, quite a large increase in toxicity. So patient receiving TDM1 had much worse toxicity than patient receiving taxane and trastuzumab. So it doesn't work. Efficacy, sorry, it doesn't work. Toxicity, huge. Well, one could argue if it was TCHP, but I don't think that cuts the thing. I think it would not have made any difference. In their hands, 1/3 of the patient could not even complete TDM1. I also find TDM1 a difficult drug. I don't know how the rest of the audience would feel about it, but I think this number of 1/3 patient not taking TDM1 is slightly on the higher side. We have data from Christine and Marianne suggesting that taxane and trastuzumab cannot be replaced by utilization of TDM1 Kadcyla. But otherwise we would have lost a lot of money with TDM1. The last is the permeation. There is a lot of discussion today about brain metastasis. So most of this discussion has actually happened. This is another small TKI available largely in China. So we don't have access to it, but this data is good. I think this has been discussed, so we can skip that. These drugs have also been discussed. Small molecule TKIs are lapatinib, which we have, neratinib, which we don't have, tucatinib, which we don't want to have because it is about 25 lakh rupees a year, pyrotinib, which is not available. These, and I forgot to write, it's 80. So in this, they had two cohort of patients. Cohort A with the de novo patient, they presented with brain metastasis and they were not treated with radiation, they were treated with the treatment. Cohort B had patients who had radiation before, were on some treatment, progressed later on, and they were treated with pyrotinib based data. So pyrotinib plus capecitabine. Primary endpoint was CNS overall response rate. So this is a slightly different population as we were discussing compared to what we were discussing before. This was early disease, no lines of treatment 36%, one line of treatment 49%. So that's an early disease. Nobody received pertuzumab, nobody received TDM1. Very much like our patient in context of inability to receive this drug. A lot of extra CNS disease. So this was a bad kind of a patient profile compared to what we were seeing before. But the water plots are very exciting. This is the water plot of cohort A when patients have not had radiation before, and this is the cohort B of the patients who have had radiation before. So ability to have an objective response rate of 74% is equivalent to what historically is ability to control the disease in the brain with radiation is, but there is no randomization here. And even in cohort B previously treated with radiation therapy, ability to achieve in about 42% and a total control rate of more than 50% is exciting. So an almost similar amount of non-CNS, that is systemic control, was observed. So this is a very good data set, though phase 2 non-randomized data set. With a median follow-up of 15.7 months, OS is yet not reached. So that's bad population, not treated with radiation, treated with small molecule TKI and capecitabine, is likely to have an OS of more than 15.7 months. I think that's interesting. But there was no data on post-trial treatment. How did they manage to have, it's a good OS for such population. This drug is very toxic. It is more toxic than lapatinib. What they say, it's a manageable to have a grade 1, grade 2 of 68% diarrhea and 63% palmoplantar dysesthesia or hand-foot syndrome. I don't agree with it. It is not manageable. Patient to go to have to the loo 3 or 4 times a day with Imodium is not manageable. They have a bad, poor quality of life whenever they have it. But in author's hand, it was manageable. A lot of this has been discussed. I think this is a good drug proven by at least 3 or 4 trials. But I think the data, if we can have it or if we can afford it at that point of time, is that of tucatinib. The data is best with tucatinib, but we just don't have access and we don't have that much amount of money to afford. But yes, this is the best data. They also talked about screening MR, and I think Bhuvan and somebody else was also talking about doing a screening MR. It's a point of contention. Pyrotinib is better than lapatinib. Multiple trials have shown, but we don't have pyrotinib. It was discussed about Emilia, Camilla, and TDXD Tuxedo trial showing some benefit as well. Well, what these trials do not answer the question, what would have been the results if radiation was the alternative? How can we say that it is as good as radiation, it's a non-randomized thing? Or what if radiation was given and this drug was given? Maybe our data would have been very, very impressive. So what is my take? My take is, if I think I'm going to give this patient lapatinib with capecitabine, or lucky to have pyrotinib with capecitabine anyway, therefore this toxicity is going to be there, then I might not offer radiation to this patient. But on the other hand, if lapatinib capecitabine or pyrotinib capecitabine is not the most standard option, then giving this amount of toxicity is not ideal, I would go for radiation. Or if the bulk of the disease is in the brain, I am not ready to forego radiation at this point of time. This is my take on it. To summarize, no role of IO, TH cannot be replaced by TDM1, and I think this is fantastic era for small molecule TKI and brain mets. Thank you.